Hello everyone, we are going to start the discussion on the ultrasounds shortly. Before I get started, I'd like to welcome you all to the Dublin Aesthetic Training. Interest with regard to this is that we do give ultrasound training. We have a three-stage process for our ultrasound. That is, firstly, an online learning course on straightforward basics of ultrasound so that you get to understand what is. Excuse me, let me just switch out the feedback. So the three stages are an online course initially to get you, give you all the knowledge that you need for using ultrasound, including the basics of physics of ultrasound, and then a sort of description of the various images that you can see. This can be done online at your leisure. Following that, we then recommend you come onto our hands-on training. This is stage 2, where we will take you through cases on normal patients and normal imaging so that you get comfortable with interpreting the image and using the ultrasound. At this stage, I really would recommend that you would have brought your own ultrasound so that you get used to it, and then following the course and immediately start putting things into practice. And that's important, because if you don't put it into practice straight away, you start losing the skill and the knowledge that you have gained. Once you've got through all of that, you then go on to the third stage, which is really using the ultrasound in true clinical practice. That is using it more for diagnosis and treatment of any complications, and using it as a newly guided treatment procedure. Before that, I really recommend you get used to just using the ultrasound to identify the structures, identify arteries, and use that in order to avoid arteries where you're injecting. So after that, you can become proficient techniques. That's how we would normally recommend you learn on stage, processes in small chunks, rather than trying to learn everything you need to know about ultrasound. Obviously, the next question is, which ultrasound do I buy? One of the questions that someone once asked me was, what's the best ultrasound? But there isn't anything called the best ultrasound. It really depends on what you want to use your ultrasound for. So, for example, let me just show you something quickly. So these are some of the ultrasounds that are available on the market. On the top left hand are two common ones that people would use, which are the Clarius ultrasound and the GEC B-scan. Personally, I tend to use this most of the time. It fits into what I want an ultrasound to do, and I'll explain to you what it does. The other one is the Philips Lumify. This is what we call a corded ultrasound. So these two, the Clarius and GEC, are wireless. They connect to either your smartphone or to your tablet wirelessly, and are very portable. The Lumify is corded, so you can see here there's a little cord attached to the smartphone or to the tablet, and then that cord comes through and is attached to the ultrasound. So it has some limitations, although in some cases it's useful to have the cord directly connected, particularly if you're in areas where Wi-Fi connectivity is a problem. The next ultrasound that's used is the Butterfly. This used to be slightly underpowered, but the newer Butterfly is slightly higher in resolution and will do its job. In terms of price, they go from the top end, the Clarius, all the way down to the Butterfly, which is around £2,500. So what are the differences? I mean, the main difference is what we call the the transducer frequency. This is the amount, this is the frequency at which the transducer is sending out ultrasonic waves. The Clarius runs at a frequency of anywhere between the L20, which is 20 megahertz, and we have an L15, which is 15 megahertz. The GEC is running, has got two different transducers. It has a transducer here, a linear transducer, which we tend to use mostly for the aesthetic use. And there is a curvilinear transducer on the other end, which we use for deeper ultrasound, such as abdomen and breast. So in my practice as a surgeon, I can use it both for superficial work around the face, or if I'm looking deeper in the abdomen, breast implants. This is quite a useful one too. So, the frequency here is running at about 12 megahertz, and the curvilinear runs at 8 megahertz. So basically, the higher the frequency, the lower the penetration. So you can see with an L20, the penetration is up to about 2 centimeters. With a 12 megahertz, you can go up to 4 centimeters, and up to about 8 to 12 centimeters. So it gives you a lot more flexibility if you're doing things like body contouring and other processes like that. The Lumify runs at about 12 to 15 megahertz, and the Butterfly is now up to about 12 megahertz. It used to be about 8, and that's constantly improving. So you need to decide how deep you want your ultrasound to go and what you would want to use it for. The other thing you really need to think about is how easy it is. These are what we call point of care ultrasounds. How easy it is for you to hold in your hand. Lumify, Butterfly, and Beatscan Air are all relatively lightweight and fit quite comfortably in your hand. The Clarius, the older Clarius, was slightly bigger. They have a newer version, the Clarius HD, which is again slightly smaller, but if you've got very small hands, you might be careful that this might be a little bit heavier. One disadvantage or advantage is that sometimes the battery on the Clarius tends to overheat. You have to then add a little cooling fan on top of the Clarius, which then makes it a little bit more bulky when you use it. GEC handheld does not tend to heat so much and has a slightly longer battery life. So in clinical use, you can find that you will be able to use it throughout the clinic, and both of these can then be popped onto an airless charger and charged. So I tend to keep it on the airless charger in clinic, so it's ready to use whenever. The image can be brought up on a smartphone or tablet. I tend to use a dedicated tablet, a Samsung tablet, that's used just in clinical practice only, so it's not being carried at all. With all of these, the other thing to also think about is the software. So what you need to know is how good the software is at showing you the images. Obviously, the resolution on the smartphone is much smaller. The large tablets get better resolution, and the software program will also show you what is coming through. In my own hands, I find that the Lumify and the GEC handheld both tend to have good software, good reproduction on the screens that we use. The Clarius tends to be variable, and it really comes down to what type of tablet you have or smartphone, and the image quality can sometimes be less than desired. In particular, the Butterflies is again very dependent on software. Again, there'll be lots of upgrades since I last used it, which was about 2 years ago, and I know they're constantly improving on their software. So software is an important thing to consider, and it might be worth having a look at some of these. The Lumify and the Butterfly are, as I said, corded ultrasound. So again, it limits the movement you can have and how you would use it. So I prefer the wireless technology rather than a cord. Just at the bottom of the screen, you can see there is one more. This is something that we are developing. This is going to be a finger-based ultrasound. So you can see this is the the prototype, it is going to be made slightly smaller. We are going to lose that lower part. It's going to be more pointed. At the moment, this has two transducers, a transducer here and a transducer here, but we're going to lose this transducer at the top and just have one transducer, so it can be finger powered. And at the moment, it is corded, whether it will be a corded ultrasound that will have a transmitter attached to a wrist, so you can then have a lot more flexibility with it. We're about 18 months away from getting that at the moment, so I wouldn't hold, I wouldn't say don't buy an ultrasound because this won't be ready for some time yet. But the top four, I think, are generally useful for what you want to do. The final thing I would caution you about when you're buying all of these is not just think about the cost. And as I said, the butterfly comes in at about £2,500. The Lumify coming in about £3,000-4,000. The GEC ultrasound is about £4,000, whereas the Clarius is between £5,000 and £6,000. So cost is something you might need to consider. The added cost on that, some of these companies will then charge you a membership fee. So for the butterfly, there is a £400 a year membership fee to have access to all the added benefits you would have, like the needle-based ultrasound guidance, some of the storage facilities that they give you. Similarly, with the Clarius, there is a membership fee that is ongoing, but I must say the Clarius do provide a lot of good educational content. GEC comes from a pedigree, as you know, GEC are well known in all hospital-based nursing. They have a lot of machines. If you go to any ultrasound department, many of them will have a GEC or a Philips ultrasound, so they come from a company that's very good at producing ultrasound, so the quality of the ultrasound is very good. There are no hidden fees. Once you buy it, that is it. You get your software, you get the upgrades with it as required, and there is no specific membership fee. You run that without any membership fee. So overall, after about 4 or 5 years, you suddenly find that the cost of the membership will have almost paid for your ultrasound. So think carefully about membership fees, what you want that membership to provide you with. A lot of the learning is available on many sites, so you don't need to. And once you start learning how to use it in practice, really that's as much as you need to get involved. One final thing to consider with all of these ultrasounds is that we now have some guidelines in using the ultrasound, so you can get all the current guidelines using ultrasound in aesthetics, and specifically on the British Medical Ultrasound Society website. So if you just go there, all the guidelines are available. That was published in October this year, which is an up-to-date guideline of what you should think about and what you should have available in your clinic when you're using ultrasound. Safety aspects are not major. Most of you who are in clinical medicine will be carrying out all the necessary safety aspects, but a few things such as which type of ultrasound you have to use and cleaning and those type of protocols are all in that guideline, so you can use that, and the manufacturer will also give you guidelines. So that really covers the things that you need to know about the different types of machines available, the software that you need to consider, the hardware that you need. Once you've got the ultrasound, then recommend you really do put that into practice, and this is where hands-on training is important. So as I said, we do that with models. We use it to use it so you can start identifying the structures, looking at those structures, and then we give you some simulated training on how to use ultrasound guided techniques and feature. But don't try and do too many complex things at once, because if you do, you'll just lose your motivation to use ultrasound. So really important to start introducing it into your practice. I personally spent a lot of the time during COVID sitting down in front of the TV, scanning my whole face, and I know now what the whole of my face looks like. I've done so I've scanned every single part of it just to see what the images look like. In clinical practice now, we scan every patient before we inject. It adds about 5 minutes to the whole consultation, because all we're doing is using the ultrasound to specifically look at the area we're going to inject to see where or if there are any vessels or anything that we might be worried about. It's very useful when we're doing masseter injections. It gives us an idea of the thickness of the masseter, how deep we need to put the needle in, and then when we're following patients up, we can actually see the masseter hypertrophy gradually decreasing in size. If I'm injecting anywhere in the soft tissue, I want to know if there's a vessel in that area. If there is, I can move my injection point to the left or right or a few millimeters away to make sure I'm not hitting any arteries. So if you use it specifically for that, it really gets you comfortable using ultrasound. Whether you want to do an ultrasound guided injection, that's, I think, more high fidelity. That's something you really need to do with a lot more experience, and only use it in specific circumstances where it's critical that the injection is placed on the right point. So that's when I would use an ultrasound injection. But complications, ultrasound is really useful if you are looking at a filler that's in the wrong place. If you want to do a needle-guided injection of Hyalase, the ultrasound comes into its own and really does help you to reduce the amount of Hyalase you use and ensure that when you do inject Hyalase, it is really up and close to the filler and it dissolves quickly. And you can see it dissolving as you're injecting and follow the patient up. So those are the main types of uses of ultrasound, and putting it into your practice, I don't think it will really take up much of your time. But once you get that confidence, you will find you can pick up the ultrasound, put it on, and very quickly figure out what's the structures you're looking at and figure out where you want to inject. So I think it would be really beneficial in your practice, and certainly in the next few years, we are going to see ultrasound as a main use in aesthetics. Aesthetics is one of the very few specialties that hasn't really taken ultrasound on. All other medical specialties have really used ultrasound and use it, but actively. That's just a real quick run through. I know some of you are late coming in, but I'm happy to open up for any questions you may have and go through queries you may have about the various devices on the market. So please do come off mute and you can ask me any questions you want.
Hi. So the reason why I've never used an ultrasound. I'm of course interested, and I've been on some presentation. I'm reading the book, and so I still doubting in very thin soft tissue like age lip or age face.
Mm-hmm.
How can we, where the vascular risk is even more present, how can we, I doubt whether the ultrasound could really be a help to avoid injecting intravascular, because in my mind it's too much, so everything is so thin that it can be useful for a pre-assessment, but I don't see how can be helpful during the treatment.
Yeah, I think to use an ultrasound during the treatment takes a lot of skill, okay? Because you're having to try, at present, the ultrasounds that we have, the Clarius and the GEC, they are relatively bulky. Okay? It's like a very small smartphone. So trying to hold that in your hand and do it with your finger is hard. It can be done, but is difficult. As I was saying, in the next few years, in about 2 years' time, we will have a little ultrasound that fits on the finger. And that suddenly makes it a lot easier. But I think the main use of the ultrasound is, as you said, pre-assess, just to make sure there's no artery where you are going to put the needle. Okay? That's the first use. The second use, which is really important now from a medical legal point of view, is we are beginning to see patients who have got filler in places they shouldn't have them. So we're seeing people with fillers too deep or too superficial, or I've got a couple of patients with fillers in their carotid gland. So from a medical legal point of view, it is really useful after you've injected to then use the ultrasound to see, show, and record an image that says that your filler is exactly where you said you were going to put it. So that you put your filler superficially when you finish. So that if anything happens later on, that could be due to product migration or something else. But at least you will have a medical record, you have an image that says you did everything correctly. And would be something that's really useful if anything became a legal issue to turn around and say, I did it correctly, it's not your fault. And that, I think, is going to be, we are in a world of defensive medicine, and it is something that you will need to have. It's no point saying, I've been injecting for 20 years, because I've seen people who have been injecting for 20 years inject into the carotid. So it is something that is, I think, going to be really important to have definite proof after injecting. So I think pre and post treatment, really, really useful. That intraoperative treatment, I wouldn't recommend you say that's what it's got to be, because it's not just. It will help if, and I'm not talking about you specifically, but all of us need to learn. I think we all have our own techniques. But when we do our technique, it's useful to then go and look to see if it has actually achieved what you wanted. And if it hasn't, then it might mean that you have to change your technique ever so slightly to make sure you're actually injecting in the right place. So that's a good way of learning things. I use it intraoperatively or intra-treatment for very complicated cases where I'm concerned, sometimes on the nose, if I've got someone who's got post-surgical, who are worried about things, then I use it. But I don't routinely use it to inject, because it's hard, time-consuming, and patients don't like you fiddling around. You just need to be able to go into it. So use it before and after. I think that's the best use.
Thank you so much. And my last question is, obviously the upper third is always such a pain. I mean, when I treat the upper third, I keep thinking about the patient the day after and the day after, and asking myself, is he cold? Has he cold already? And so it's upper third, it is still a bit of concern. So, for example, you can pre-assess the temple area. You can pre-assess the vascularization in the temple area. Can you see after the treatment a change in vascularization that may lead you to imagine that, to suspect that the filler is creating a kind of compression or a reduced vascularization of the area? And to conclude, I have this feeling that key opinion leaders are using the ultrasound to learn, and you are learning and you are teaching us a lot of very interesting things. So thank you for that. But with a more extensive usage of ultrasound, I fear we are going to use a lot of more hyaluronidase and dissolve a lot of more, just because we imagine that something that is not the right place it's not the right plane layer. It's, you know, so there is a little risk that we kind of overestimate the severity of a clinical.
No, to take your first question about the vascularization, particularly upper third, it's two things about the upper third. The anatomy is much easier to see with ultrasound in the upper third than the lower part, okay? Very much easier because they are very strict layers and you will see those layers very clearly. So it's a really good place to use it. You can also see the flow in the blood vessel. So for example, the supraorbital or supratrochlear or even the superficial temporal, you'll be able to see the flow. One of the first things you will see if your injection is too close to the artery or is beginning to swell, you will actually see the flow decreasing. And if you see that, then you know that there's a potential problem. And that's when you can do, that's when a needle-guided ultrasound with hyaluronidase is important, because you can just put a tiny amount. You don't have to flood the area and use large doses. 20, 30 units of hyaluronidase, just where it's near the artery, will reduce the pressure and you can sleep easily. So you will see that. But I take your point. There may be earlier on people who get so concerned they'll use a lot more hyaluronidase. But you know, if they do, they'll probably still only be using smaller amounts. Some people are beginning to call it the micro hyalase injection because they're using small amounts. But I think people will, once you get comfortable and confident, you will know where you can inject and you won't worry so much. But please do go ahead, find a machine you like, and then we'll be happy to see you if you want to come and do some hands-on with us. We have some courses where you can just practice. And once you start seeing the image, once you start understanding what that image means, it becomes very easy to use. Because the majority of the images you see are standard. Most of our patients are healthy patients with normal type anatomy. You're not looking to diagnose any odd conditions or things. You just see normal images. Okay. Well, I look forward to seeing you. Take care. Soraya, are you all right? Have you managed to get on? Well, I shall let you get home. I know your clinic's finished, so you probably want to go home. So leave you all to go home and look forward to seeing you all very, very soon. Okay. Take care now. Bye-bye.
Thank you. Bye.
Thank you very much, everyone, for coming along for this meeting.